Today, we are going to understand a very rare but clinically fascinating thyroid condition called Riedels thyroiditis. And we will do it by walking step by step through this case sheet in front of us. Imagine you are in a clinical exam or ward setting, and this is the patient being presented to you. The key here is not just to read the case, but to interpret every single finding and understand why it is happening. So starting with the patient details, we have a 52-year-old female. Now even this simple piece of information is important. Many thyroid disorders, especially chronic and autoimmune-related ones, tend to occur more commonly in middle-aged women. So right at the beginning, this demographic already aligns with thyroid pathology. She is a school administrator, which tells us she has likely been functional for a long time, meaning this disease has had a slow progression rather than a sudden disabling onset. Now moving to the presenting complaints, which are extremely crucial in guiding our thinking. The first thing mentioned is a slow-growing, painless, very hard neck mass. This combination is highly significant. Slow growth tells us this is not an acute, inflammatory condition. Painless nature further supports that we are not dealing with something like subacute thyroiditis. Instead, we start thinking of chronic processes such as fibrosis or even malignancy. But the most striking word here is very hard. In clinical medicine, when something is described as stone hard, it immediately narrows down the possibilities to either malignancy or a rare fibrosing condition like Riedels thyroiditis. The patient also complains of a choking sensation, essentially dysphagia. Now anatomically, the thyroid gland lies very close to the esophagus. So if a patient feels difficulty in swallowing, it suggests that the mass is large enough or invasive enough to compress the esophagus externally. This immediately tells us that the disease is not confined within the thyroid capsule, but is extending beyond it. Next is shortness of breath on exertion. This is another important symptom because it indicates tracheal involvement. The thyroid gland lies just in front of the trachea, so any enlargement, especially a rigid one, can compress the airway. Initially, the patient may not feel breathless at rest because the airway is just sufficient, but during exertion when oxygen demand increases, the limitation becomes apparent. This gives us a clue that there is dynamic airway compromise. Then comes voice change or hoarseness, which is one of the most important red flags in thyroid pathology. This happens due to involvement of the recurrent laryngeal nerve, which runs very close to the thyroid gland. If the nerve is compressed or encased, the vocal cords cannot function properly, leading to hoarseness. So now, combining dysphagia, breathlessness, and hoarseness, we are clearly seeing a pattern of local invasion into surrounding structures. Moving on to the past medical history, we see that the patient has had a slowly progressive neck swelling over the past 2 years. This long duration is very important. Malignancies usually progress faster, and inflammatory conditions are typically shorter in duration. A 2-year history strongly points toward a chronic fibrosing process. There is no prior history of thyroid disease or autoimmune disorders, which might seem surprising, but Riedels thyroiditis does not always present with classic autoimmune markers. However, there is a mention of possible past fibrosing conditions like retroperitoneal or mediastinal fibrosis. This is a very significant clue because Riedels thyroiditis is often associated with a broader condition known as Ig-G-phorylated systemic fibrosis, where multiple organs develop dense fibrotic tissue. Now looking at the general examination findings, the patient has normal pulse and temperature. This is important because it rules out hyperthyroidism and infection. So despite having a large neck mass and compressive symptoms, the patient is systemically stable. This again supports a non-inflammatory, non-toxic process. The real diagnostic moment comes in the local examination. The thyroid swelling is described as asymmetrical, fixed, and very hard. The word fixed means it is not freely movable, indicating that it is attached to surrounding tissues. The stone-hard consistency is due to dense collagen deposition replacing normal thyroid tissue. This is why Riedels thyroiditis is often described as having a woody thyroid. At this point, the main differential diagnoses would be thyroid malignancy and Riedels thyroiditis, because both can present with a hard, fixed mass. Now, when we move to systemic examination findings, we start understanding the full extent of the disease. The thyroid is described as a fixed, rock-hard mass with tracheal deviation and compressive narrowing. This explains the breathing difficulty. There is also esophageal compression, explaining dysphagia. The recurrent laryngeal nerve is encased, explaining hoarseness. Additionally, the carotid sheath is involved, which is a very serious finding because it indicates deep infiltration into major vascular structures. This pattern of spreading beyond the thyroid into adjacent structures is what makes Riedels thyroiditis mimic malignancy clinically. Now let's understand what is happening inside the body in terms of pathophysiology. We start with a normal thyroid gland. Then, due to an unknown trigger, possibly immune-mediated or related to IgG4 disease, there is activation of fibroinflammatory pathways. This leads to proliferation of fibroblasts, which start producing large amounts of collagen. This collagen gradually replaces the normal thyroid tissue. Unlike tumors, this fibrotic process does not form a proper capsule, so it spreads outward into surrounding structures. Over time, the gland becomes completely replaced by dense fibrous tissue, leading to the characteristic hard consistency and compressive symptoms. If we break this into stages, initially there is inflammatory infiltration, followed by fibroblast activation and collagen deposition, and finally extensive fibrosis, leading to compression of adjacent organs. This explains why the disease starts subtly and gradually progresses to severe compressive symptoms. Coming to investigations, thyroid function tests are often normal, meaning the patient is euthyroid. This is because enough functional thyroid tissue may still be present in early stages. However, as fibrosis progresses, hypothyroidism can develop. Thyroid antibodies are usually low or negative, which helps differentiate this condition from Hashimoto's thyroiditis. On ultrasound, the gland appears heterogeneous, hypoechoic, and ill-defined, indicating diffuse infiltration rather than a well-defined nodule. CT or MRI of the neck provides a better picture of the extent of disease, showing an invasive, unencapsulated mass involving adjacent structures. This is very important for assessing severity and planning management. The most crucial investigation is histopathology. A biopsy shows dense, hypocellular fibrous tissue with extensive collagen deposition and very few inflammatory cells. This is the key feature that differentiates Riedels thyroiditis from malignancy, which typically shows high cellular activity. Fine needle aspiration often fails in this condition because the tissue is too fibrotic to yield sufficient cells, making it non-diagnostic. Now coming to management, which requires careful clinical judgment. The first line of treatment is medical therapy. Glucocorticoids like prednisolone are used to reduce inflammation and may slow down the fibrotic process. Another important drug used is Tamoxifen, which has antifibrotic properties and helps in controlling disease progression. Surgical management is not straightforward in this condition. Unlike thyroid cancer, total thyroidectomy is avoided because the gland is densely adherent to surrounding vital structures like the trachea, esophagus, and major vessels. Attempting complete removal can lead to serious complications. Instead, limited surgical decompression is performed only to relieve pressure on the airway or esophagus. Finally, long-term monitoring is essential. If the patient develops hypothyroidism, thyroid hormone replacement is given. More importantly, since this condition can be part of systemic fibrosis, the patient must be evaluated for involvement of other organs, such as the retroperitoneum and mediastinum. So to conclude, whenever you encounter a patient with a stone-hard thyroid mass, compressive symptoms like dysphagia, breathlessness, and hoarseness, and imaging that shows an invasive pattern, but histology reveals dense fibrosis rather than malignancy, you should strongly consider Riedels thyroiditis. This condition teaches us an important clinical lesson that not everything that behaves like cancer is actually cancer. And understanding this distinction can significantly change management and outcomes.